Hello, this is Bradley Graw, one of the joint replacement surgeons at Palo Alto Medical Foundation. This is our nuts and bolts seminar for patients, friends, and family for those undergoing a hip or knee replacement. Thank you for watching this video. This does not replace the in-person seminar that we hold a couple times a month in Palo Alto. Please do not hesitate to contact us at 650-853-2018 to get the times of those talks. They are most often given in the afternoon on Friday. However, for those not able to attend in person, thank you for watching this video, which will go for about 60 minutes. I will mention some commonly asked questions at the end of the talk, but the in-person seminar also offers that benefit of hearing what other people have to say and ask. With no further ado, I will begin this introduction to joint replacement. Again, we call this the nuts and bolts talk for those going through surgery. Most people who attend this talk in person and who are watching this are those who have already decided to have surgery, although this does confirm some of the key aspects of the surgical process and risks. And please understand that if you do have any hesitancy, please talk to your surgeon and surgical team about those questions, and you can cancel or postpone surgery at any time. We want you to feel comfortable with this process and be safe going through it and have a good experience. Again, the goals of this talk and of our team at the Palo Alto Clinic Center for Total Joint Replacement are to help you go through a hip or knee replacement in a safe and comfortable way with the best long-term outcome possible. We feel that educating you and family members and other people of your care team is going to help you towards the best result. Thus, the educational materials we have here and the lines of communication that we have for you. Please share this information and other information that you get from us with family and friends. As you go through this talk, do look for the star that's shown in the bottom right-hand corner. This has key information for you and your family and friends to help you go through this process safely. It really takes a team to help deliver this safe, effective care for you. A hip and knee replacement, the procedure itself happens in the operating room, but there is so much behind the scenes to help you smoothly get through this. So please recognize that there are a dedicated team of medical assistants, nurses, physician's assistants, surgeons, and operating room personnel helping you. Some of these people are represented here. This is our team at Palo Alto. Our surgeries as of spring 2019 are performed at Sequoia Hospital in Redwood City, California. We have a long-time relationship here, going on 10 years. The hospital is part of the Dignity Health System. It is a CMS 5-star hospital for low complication rates, low infection rates, and highly satisfied patients going through the Center for Joint Replacements. There are about 1,000 hip and knee replacements per year that we perform at this hospital. There is a national quality organization called NSQIP that has recognized our performance in the top 10% nationally for low infection rates and low complication rates. The U.S. News and World Report also ranks hip and knee programs, and we've been noticed as a high-performing program. Much of this has to do with the partnership with the physicians from the Palo Alto Clinic. This includes our surgeons, of course, also anesthesiologists, hospitalist physicians, and other specialists as needed as you are going through your care. During the talk today, I'm going to talk about the journey of getting a hip and knee replacement. There are 6 boxes here which are related to 6 topics that are important. I will touch on each of them. First of all is, are you ready for a joint replacement? Next, if you are deemed to be ready, how do you get scheduled and prepared for surgery? Next is, what does the big day of surgery itself look like? After that is your hospital stay. Most people stay in the hospital for 1 to 3 days after a hip or knee replacement. Most people then go home. There are a percentage of people, about 10%, that may go to a skilled nursing facility. And then important for everyone is the long-term follow-up care to ensure your best long-term outcome and survivorship of your joint replacement. So what about knee and hip pain? If you have knee and hip pain, not everybody, of course, should be considering a joint replacement. But if you have failed non-operative and other alternative treatments, you might consider a joint replacement. Treatments that you should have considered include modifying your activities, managing your weight, physical therapy and strengthening around the joint, the use of anti-inflammatory medications, the use of injections and bracing, and in this case mostly for the knee, and the consideration for joint preservation surgery, especially for those under the age of about 50. However, if these treatments have not helped you and you have significant degenerative disease, as you see on the x-ray here to the viewer's left, where there's a decreased joint space around the knee and significant osteophytes, which are bone spurs, you might consider joint replacement surgery and meeting with a surgeon. If you see a surgeon and you become comfortable with the risks and the process, understand that you may be a candidate for total knee replacement. In this case, this is a hip that is significantly degenerative with a flattened femoral head. The femur is the thigh bone, and what should be a round ball and socket, as you see on the viewer's left, does not look like this on the right. This person has lost the cartilage space and actually has started to damage the bone. So, if you'd like to get back to activities, whether it's walking, being with family and friends, sporting activities, and living without pain, you might consider a hip or knee replacement. This is what a knee replacement looks like in concept. There are 4 main parts that we use. Shown here are 3 of them. On the top is the cap of metal that's placed on the end of the femur. On the bottom is a metal tray that's placed on the top of the tibia or the leg bone, and in between is a plastic liner that sits between the two. That makes up the bearing surface, or the part that moves on itself. There's also a small plastic disc that goes underneath of the kneecap. In the United States, the majority of knee replacements include the patellar or kneecap portion, and the majority are cemented into place. There are many different types of designs and such that you can talk with your surgeon about. This is what a knee replacement looks like implanted in the body. You can see the metal cap on the end of the thigh bone, the metal tray on the top of the leg bone, the gray cement holding the tray in place, and a gap between the two, which is that plastic that is not shown on the x-ray. Next is a hip replacement. Hip replacement most of the time is placed in a cementless fashion if somebody has good bone. There are also 4 parts. There's a part that goes into the thigh bone, we call the femoral stem. There's an acetabular or cup component that goes into the pelvis. And then there is the bearing surface. In this case, there's the pink ball, which is ceramic, which is commonly used as of 2019, and a plastic liner called the polyethylene. This mates together, has a low wear rate, and can last for a long time, over 15 or 20 years in most patients. If your bone is weaker, you may have this component cemented into place for safety at the time of surgery to decrease the risk of your bone being broken during the insertion of this part. This is what a total hip replacement looks like in concept implanted in the body. Again, you see the femoral stem, you see the metal acetabular or cup component, the ceramic ball, and then a small gap where the plastic liner is placed. There are also, in this case, two screws that hold the cup into position that I routinely use in my practice, as do many other surgeons. Why do we have a picture of Harry Potter here? Well, life would be easy or easier if we had a magic wand to place these hip or knee replacements, but we don't. There is a process to safely insert these parts and get you through the rehabilitation process. We have made it a lot easier over the past 10 to 15 years in terms of getting you through this comfortably and safely. And realize the reason that we bring people through this process, especially those who have failed the non-operative treatments, are that the outcomes of hip and knee replacement are almost uniformly excellent. More than 90% of hip replacement patients are very satisfied when asked about their experience and overall pain relief and mobility improvement. With knee replacements, the number is just under this at about 85%. And the survivorship of these implants is more than 15 to 20 years in 80% of patients. After the first year of surgery, should there not be a complication, which we will discuss, the failure rate is about 1 to 2% per year, which means that many joint replacements will last a patient's entire life. We've been measuring patient-reported outcomes over the past several years, and in the case of hip and knee replacement, there is consistent improvement from before surgery, as shown on the left on this slide, for the preoperative number, to after surgery at 12 months. In fact, there's significant improvement right away. When patients are asked about day-to-day activities and pain and mobility improvement, there is significant improvement with these procedures. There are risks, however. So if you are considering surgery, you should understand the risks that are inherent to getting a hip or knee replacement. We have worked very hard to keep the rates of complications and readmissions to the hospital low, but they still can happen. Within 3 months of surgery, it's about a 5% rate of some type of complication, whether small or large, that we have to deal with. Infection and blood clots are two of the major issues that we have worked to improve and decrease the risk of over time. Around the country, it's about 0.5 to 1% nationally of getting an infection around a joint replacement. This is a disastrous problem for people, and we ask you to take the prevention of infection very seriously. The reason it's such a problem is that if bacteria gets on the metal and plastic parts which I showed you, it may require additional surgery even to have the parts taken out. This can be a 4 to 6 month process and quite disruptive to your life and to our practice. Thus, we work very hard to bring the infection rates down, and within our practice, we've had several years with actually no infections in a row, but we continue to be proactive. Blood clots can also be a problem after surgery. Blood clots can also be fatal, although this is a rare event at this time. The reason it is a rare event is we are very proactive about limiting this. Blood clots can happen because of the immobility after surgery, because of the trauma at the time of surgery. Some people are also inherently at risk for blood clots. So if you have a history of a blood clot or a family member does, especially in the lower extremity, please tell us. We also get you moving quickly after surgery to help blood pump and get back through your body so that it does not clot. And we also recommend pharmacologic therapy, medications to help the formation of blood clots from happening. I will talk quite a bit about this in this talk and in our in-person seminar. Both hip and knee replacements can have mechanical issues around the joints as well. Stiffness is a problem in knee replacements. Several percent of patients may even need to go back to the operating room for what we call a manipulation of the joint to break up scar tissue. Physical therapy is absolutely necessary surrounding getting a knee replacement. Without doing physical therapy, you will not be happy, as the joint has a high rate or probability of becoming stiff. Hips, however, don't have the problem of stiffness, but can have an issue surrounding instability or dislocation of the joint. This risk has come down over time, but can still be a problem. It's less than 1% that this occurs because of our improvement in techniques, and also because we make sure that you follow specific precautions around the joint for about 6 weeks after surgery. I will talk to you about this in further detail here, and also the physical therapy team will talk to you about this throughout your recovery. This is for 6 weeks. Dislocations can happen at any time, but the risk goes down quite a bit as you get 6 weeks beyond surgery. When hip or knee replacements are placed in the body, the bone can be broken. This is called a fracture. If there's a fracture, this is fixed and treated. It will slow down your recovery, but can be a disruptive event. We do a lot to try and limit the chance of a fracture, but realize that this can still happen around a hip or knee replacement. Nerve or blood vessel injuries that are significant, albeit limb-threatening or to threaten the function of the lower extremity, are rare, well less than 1%. Injury to superficial sensory nerves, however, is common on the outside of the knee and on the outside of the hip. Some people may have permanent numbness, and it's important to understand this, although this is just around the surgical site itself. There are some patients who have incomplete pain relief. So when we look at people who are not happy with joint replacement, many of them may have persistent pain. This is a relatively uncommon scenario, but can happen around knee replacement more than hip replacement. In some ways, we don't know why this is, and we do work to try and figure out exactly why. But realize that, especially in knee replacement, you are not getting a normal knee, you are getting a better knee, and there will be some continued pain. Leg length discrepancy, or the feeling that one leg is shorter or longer than the other, can happen after hip or knee replacement. This is more commonly an issue in hip replacement, although we have worked very hard to limit the variability here and use specific technologies to limit this. But a few percent of patients after surgery may feel compelled to wear a small lift in your shoe after surgery to create a more equal feeling limb length. For the first 3 months after surgery, especially after hip surgery, the operative leg will feel long because the muscles have not tightened up after surgery. This is also something to remember. As we get to the bottom of the surgical risks, realize that there can be serious medical complications, whether it be heart attack, stroke, or death. We realize in Medicare populations, the risk is actually quite low, about 3 out of 1,000, but this still can occur. This tends to be less for younger patients. So these are the major surgical risks. Anybody deciding to have surgery should realize that these things can happen. The rate overall is about 5%. Infection and blood clot can be a very big problem, and we work to limit the risk of these issues and all the others on this list. Our goal, again, is to keep you safe. You also should understand that some risks can be modified. Some of the major risk factors are listed here, including obesity, smoking, diabetes, use of chronic pain medication, psychiatric issues, and dental or other chronic infections. Obesity is a risk factor for infection and reoperation after surgery. Likewise, smoking and diabetes are also risk factors. Chronic pain medications before surgery can make recovery more difficult and the chance of joint stiffness and dissatisfaction higher. And dental infection, which will be reiterated later, also is a risk for infection around a joint replacement in the short and long run. Please talk with your surgeon and your clinical team on how to modify these risks. If these criteria are too extreme, you may not be offered surgery based on obesity and diabetes metrics. So, if you have failed non-operative treatments, if you are comfortable with the nature and process of the surgery and the potential risks, this is all important to your understanding of informed consent for hip or knee replacement. Our goal is for you to feel comfortable with the process and the team, and you will be asked to sign an informed consent before surgery. So, with no further ado, now let's move on to what does the process of surgery look like? How do I sign up for surgery? What does the day of surgery look like? And what about my recovery? So, again, this is a picture of our team. In my practice, Jennifer, my nurse, as of spring 2019, serves the role to schedule your surgery and find a date for your surgery. She will also bring you through much of the nuts and bolts in terms of the things you need to do to prepare. She's your main point of contact within the clinic. Billing issues are dealt with through our financial department. Depending on your insurance, you'll need to contact a specific person. In regards to Medicare, you will need to contact them directly. If you have a PPO insurance, the phone number is here. And if you have an HMO insurance, the phone number is the last on the list. There are many things to do before joint replacement surgery. Here are some of the key ones. You need to see your primary care doctor within 30 days before the time of your surgery. You also need to get appropriate lab and EKG work before surgery. Jennifer can help order this for you. You need to ensure you have no active infections. Critical ones are dental infection, especially of your gums, or skin infection, especially on the lower extremities and along the leg where you are having surgery. You will also need to go to the Sequoia Hospital pre-op department within 2 weeks of surgery. If you have any specific medical issues that are cared for by a specialist, you may also need to see one of the specialist physicians, and you may also need specific preoperative tests. In the case of heart problems, you may need to get an echocardiogram or a stress test. And in the setting of diabetes, you may need to have your hemoglobin A1C monitored, which again is a measure of blood sugar control. Importantly, if you are a rheumatic, you will need to have specific management, often holding specific rheumatologic medications before surgery. The preoperative clinic at Sequoia Hospital is important for you to visit 1 to 2 weeks before surgery. Their phone number is here. At that clinic, you will be type and screened for blood. That means a small sample of your blood will be taken. While it has become very rare, less than 2%, to get a blood transfusion after surgery, there still is that possibility. It's most safe that we have a type of your blood in case that needs to happen. You will also have a swab of your nose to be tested for a particular resistant bacteria called MRSA. We use a special antibiotic to help treat this if that is the case. You will also get a kit to include chlorhexidine soap to help limit the amount of bacteria on your skin as you get ready for surgery, all in the impetus of decreasing the rate of infection for you. Here's a picture of a messy house. The question for you, though, is your home ready for you to go home safely and comfortably after surgery? A little bit of preparation can go a long way. Your house doesn't need to be particularly pristine, and in fact, this architectural digest picture may not be best. But here are some tips for you to go home safely in terms of how your home is set up and other arrangements that you should make. In terms of getting your home ready, you should have some household help, especially for the first couple weeks after surgery. You do not need to have someone living with you full-time to help, but someone to check in on you 2 to 3 times a day is best. This is for groceries, meal prep, house cleaning, and other day-to-day tasks. In terms of pathways in your house, most people use a walker for the 2 weeks or so after surgery. You do want to move furniture and clutter, and you should have paths wide enough for a walker, just about over 2 feet. You'll be needing to go, of course, to the bathroom, the bedroom, and the kitchen. You also want to eliminate trip hazards, so taking away loose rugs and other items that you can trip over are important. Last on this slide are meals. There are many meal delivery services in the Bay Area, but buying groceries ahead of time, making and freezing simple meals is a strategy that can help. And of course, having family and friends bring some of your favorite meals after surgery can also be helpful. Living areas should be placed within everyday reach for you. Pet care should also be arranged. Remember that you will be the one requiring care, and you are not going to be the best caregiver for somebody else or a pet for the first several weeks after surgery. You also want to be aware that there are no pets getting near your incision after surgery, again to decrease the risk of infection. In your bathroom, you don't need to place any specific new handrails or other types of durable equipment, but a non-skid bath mat is important. And in regards to furniture, think about a chair that's stable and limiting your chance of falling, whether out of a couch or a chair, during your recovery. Most people have the question about when is the time of my surgery. The way this happens at Sequoia Hospital at this time is the hospital finalizes the schedule based on many different variables and will call you during the middle of the day or early afternoon the day before surgery. You will have to be at the hospital about 2 hours before surgery, however. First surgery of the day is at 7 a.m. That means the first patient of the day will need to get to the hospital around 5 a.m. If you have the last surgery of the day around 2 in the afternoon, you would have to arrive by noon. Realize that you need to designate someone to drive you to and from the hospital. At this point, ride shares like Uber and Lyft are not ready or secure or safe enough for this purpose in the eyes of the hospital. You have to have somebody responsible to transport you. Family and friends, again, should be available to check in on you for the first couple weeks after surgery. And if you don't have somebody to do this, our nurse navigator at the hospital, whose phone number will be provided for you, can help with other resources. When you come to the hospital, you want to bring an accurate list of medications. Your primary care doctor should have gone over this with you, but please bring an accurate list so that the nurses and team can reconcile this when you are admitted to the hospital. What about packing? What should you bring to the hospital for this 1 to 3 day stay in the hospital? There's no need to bring valuables to the hospital. You do want to bring loose-fitted clothing, non-skid closed-toed shoes, toiletries, books and lightweight electronics, and importantly, personal medical supplies. A CPAP for those with sleep apnea, glasses, and hearing aids. In regards to medications, unless you have a medication that is specifically rare, you do not need to bring this to the hospital. If you have a question, please call the hospital pharmacy. The days before surgery, here are some important things to remember. You do not want to take any bleeding agents for a week before surgery. Most commonly, this means no ibuprofen, no naproxen, and no aspirin. If you are on a prescription blood thinner, you must have a plan. More commonly, this is Xarelto or Eliquis. This generally needs to be held for 2 to 3 days before surgery, and you may need a bridging therapy or injection based on your medical problem. This should be arranged through your primary care doctor and or cardiologist and confirmed with our team. For Women, no shaving near the surgical site of the hip or knee for 5 days before surgery. The reason for this is this can increase your risk of infection. You'll have a special razor used at the hospital that does not include this risk. You also want to limit alcohol the days before surgery. And importantly, you don't want to have anything to eat after midnight the day before surgery. What is a relatively new protocol is that you can have clear fluids up to 2 hours before the time of surgery. This can help with your recovery in terms of not being dehydrated, having less nausea, and generally feeling better. Importantly, you need to clean your skin with chlorhexidine, and I will tell you the details in a moment. This is a surgical prep kit that you would get from Sequoia Hospital. This tells you how to use the chlorhexidine soap to limit the amount of bacteria that you have on your skin before surgery. This helps limit your risk of infection. Here are some of the highlights. Please follow the instructions as shown on the previous slide, and after using this, use clean towels, clean pajamas, and sheets so you don't get more bacteria on your skin after having cleaned it. You don't want to have any pets in bed with you, as had been mentioned, again, to decrease the burden of any bacteria close to your surgical site. Again, the goal is to limit your risk of infection and keep you away from any deep infection, which can mean additional surgery. So, having gotten prepared for surgery, having seen your primary care doctor, having gone to the preoperative department, and coming with clean skin and a time to be at the hospital, you need to arrive at Sequoia Hospital. This is the front of the hospital. You'll be there, of course, 2 hours before the time of your surgery. You will be ushered to the preoperative holding area. This is where nurses will get you ready for surgery. This is where your surgeon will see you, as well as the anesthesiologist, and the final boxes will be checked, and you will be prepared for surgery for your hip or knee replacement. This is a famous letter with John Hancock's name on the bottom of it, and you will get the John Hancock of your surgeon's initials on your hip or knee. These are my initials, BG, on one of my patient's hips. This is important so that we identify the correct side and joint that you are having replaced. We haven't gotten this wrong yet, and we don't plan on getting this wrong anytime in the future. You will also meet with the anesthesiologist. This is an important slide. Many people have questions about anesthesia, understandably so. If you have many questions or you have a complicated medical history, we may ask that you speak with one of the anesthesiologists before surgery through having a consult with one of them. However, for most patients, more than 90% of people are getting a spinal anesthetic at the time of surgery with a varying degree of sedation, ranging from mild sedation to deep or general anesthesia. With any degrees of sedation, you should not have memory of the surgery, which is what many people ask. For pain control after surgery, we ask all of those who are getting a knee replacement to get a nerve block, which the anesthesiologist will place in the operating room. So, you'll meet with the anesthesiologist to confirm the plan while in the preoperative holding area. And remember, the final decision is between you and the anesthesiologist. Then you are wheeled off to the operating room. The surgery itself takes about 60 to 90 minutes, but the total time in the operating room is about 2 to 3 hours. This includes time for anesthesia, adequately positioning you, and placing bandages before getting you to the recovery room. Realize that revision surgeries, those are second-time surgeries, and larger patients can take longer amounts of time, sometimes beyond this window. During this time, of course, your family members cannot see you. They also cannot see you in the recovery room, but we want to make sure they're close by and share their phone number in case we need to contact you. This is most often to tell you how well the surgery went and when to expect your family member on the recovery ward. But patients will be in the recovery unit or the PACU for about 90 minutes after surgery. This is to make sure vital signs are stabilized, pain is controlled, and the spinal anesthetic is appropriately wearing off. Then you will go to the total joint recovery unit, which is presently on the 3rd floor of the hospital in the new pavilion at Sequoia. This is where most people stay for 1 to 3 days after surgery to recover. The first day of surgery, many people will work with a physical therapist briefly that evening to sit at the edge of the bed and take a few steps. But generally, you are tucked in for the night, you are kept comfortable, and much of the work happens the next day. Let me tell you about the overview for those getting a total hip replacement. The stay in the hospital is about 1 to 2 days. On that first day, about 80% of people get physical therapy. The day after surgery, or day 1, this is when you're starting to eat a regular diet. If you have a bladder catheter placed, this will be removed. If you have a drain placed, this will be removed. And you will get 2 sessions of physical therapy, a session with occupational therapy, and a case manager who will be assessing your situation and what your needs will be for home. On the second day, you'll be transitioned to oral pain medication and continuing with physical therapy. Some younger patients will be discharged on that first day because they are safe and interested in going home. On either day that you go home, checkout at the hospital is 11:30 a.m. on the day of surgery, or on the day of discharge, I'm sorry. For knee replacement, because the procedure is more painful and because the nerve block which is offered will wear off after a day or so, the hospital stay is a bit longer. The activities are the same, but realize that we want to make sure that your pain is controlled once those nerve blocking agents wear off. So, patients tend to leave the hospital on the 2nd or 3rd day, given that circumstance. And again, the discharge time is 11:30 in the morning on the day of discharge. You will meet a lot of people at the hospital working on instituting your care and getting you through this safely. This includes a hospitalist physician, also known as an internal medicine physician from the Palo Alto Clinic. They will work on medical issues for you, including blood pressures, medications, and other nuanced issues for your care. They do not work on surgical issues or look at your bandage or care for you if there's a surgical problem. There's also specialized nursing staff who will be working with you, and physician assistants and nurse practitioners who are our extenders and help with some of the details of your care and pain management surrounding your time in the hospital. They also help with some of the detail work for your discharge from the hospital, and that type of planning. You will get to know physical therapists and occupational therapists well, and we'll go into those details in a moment. And also the case management staff will be looking at your case, and there's a nurse navigator who you may have met before your hospital stay who will also check in with you while you were there. Remember, the hospital is not the Ritz-Carlton. It is a hospital. There are alarms and tubes and nurses checking in on you. It's not a great place to sleep. That being said, most of our patients are generally satisfied with the stay in the hospital, but realize that there are oxygen saturation monitors, IVs, catheters, drains, vital sign checks, and nursing checks that can be quite disruptive. So bear with the nurses as they do their job. This is to keep you safe. A big part of the reason you're in the hospital is to stop the pain and realize how much pain you're having and make sure we have you on an appropriate regimen of pain control after surgery. This means that we'll be using a cocktail of medications, trying to limit the amount of narcotic medication that you need to take after surgery. Let me tell you more about this. The main reason you're in the hospital again is for pain control. We use a multimodal approach which begins in the operating room and before, including spinal anesthetic, nerve blocking agents, local anesthetics, and oral pain medications. The oral medications include anti-inflammatories, nerve modulating agents, and long and short acting narcotics. There are backup intravenous pain medications as needed, but we try to keep people away from these except if pain is very severe. Realize that pain control is not always easy. People are different in regards to their perception and requirement for medication. We are also in the opioid epidemic era, and we're trying to limit the amount of narcotics because of the problematic side effects and addictive potential. So please be sensitive as we work through this and try and keep you as comfortable as possible and progressing safely. In some ways, nausea can be worse than pain. So please start slowly with food. Starting with clears or with Jello is the right thing to do at first. Usually the next day, moving to solid food is safer and more comfortable. But there are anti-nausea medications available. This includes medications that are quite strong and used for cancer patients. There are lots of agents to try if you do have nausea, so please speak up to the nurses so that we can help you out. Fever after surgery. First of all, remember that fever after surgery does not mean infection. It's very, very common. The most common reasons at first, for the first few days, are atelectasis or microcollapse of the lung and pooling of the blood in your legs. Both of these issues can lead to low-grade fever. To help prevent this, please use this device shown on the bottom left of the screen called an incentive spirometer. You don't blow into this device, you inhale on the device. You want to use this several times an hour while you're awake. This helps keep your lungs open and keeps you from developing a fever. The blood pooling is best modified by getting up and moving and pumping your legs up and down and using the pumps around your legs that I'll describe later. That being said, you can have fever that signals a problematic infection. This includes a urinary infection, pneumonia, or a wound infection. This usually occurs several days after surgery. If you have a higher grade temperature, 101.5 is a usual threshold that we look at. If you have any symptoms of burning on urination, problem with your wound, or a productive cough, please contact us so we can see what the diagnosis is. Now let's talk about blood clots. This is a serious topic because there had been cases of fatal blood clots more commonly as joint replacements and many orthopedic surgeries were first done. That being said, we're very proactive again about limiting this and also educating you about a blood clot and what it looks like. A blood clot in our case, we will call a DVT or deep venous thrombosis. That is a clot in the veins in the legs. It can be in the calf or in the thigh. The problem is it can propagate and the clot can break off and go to your lungs, which can be a pulmonary embolus. Some people can be supported through pulmonary embolus. Other people, it can be fatal. So we want to prevent the formation of a blood clot. The early modes of prevention are mobility, the use of compression devices, and medications. So please take this seriously. Getting up, moving safely, using the compression devices around your legs, and understanding the medications is important. If you have a blood clot, it can sometimes be difficult to diagnose. But if you have swelling in the leg that's persistent and it persists despite elevating the leg, we may have you go to the urgent care or emergency room to be tested for this with an ultrasound of the leg. If you're having shortness of breath, chest pain, fainting, or losing consciousness, this is concerning for the possibility of a pulmonary embolism. You should call 911 or go to the emergency room right away. Along the lines of emergencies, please call the nursing staff while you're in the hospital if you're having intractable pain, shortness of breath, irregular heartbeat, or chest pain. If you have a family member nearby and you're not getting a response from the nursing staff, have them go find the nursing staff immediately. They will contact the PAMP hospitalist if there's a specific medical issue, and they will contact the orthopedic surgeon if there is a surgical issue. But they can't contact us if they don't know, so please talk to the nurses. Here are some tips for sleeping in the hospital. First of all, ask for a sleeping pill if you need. We tell you this because the patient that sleeps better at night will be nicer to their doctor in the morning. Also consider using earplugs or eye shades that are often given to you in the hospital. Let's talk about physical therapy, first of all for hips and then for knees. Around hip replacement, it's all about learning the anterior hip precautions. It also means not doing too much too early. The reason is the soft tissues are still healing and the prosthesis is most likely incorporating into the bone. So please hold the hip precautions to prevent dislocation for 6 weeks after surgery. After 6 weeks, you'll be able to relax those precautions most likely and also begin strengthening around the joint. We recommend physical therapy in the hospital, at home for 2 weeks for safety, and optionally beginning outpatient physical therapy 5 to 6 weeks after surgery. The positional precautions around the hips are the following. You don't want to hyperextend the hip, you don't want to cross your legs, and you don't want to break 90 degrees of flexion at the hip. This is for 6 weeks. This is to prevent dislocation or the ball popping out of the socket. What about physical therapy for the knees? Remember that knee replacement is a physical therapy dependent procedure. You need to get your range of motion generally early to benefit from the knee replacement. Physical therapy starts in earnest in the hospital, then transitions to home and lasts for 4 to 12 weeks after surgery. We're not worried about dislocation as we are on the hip, but we are worried about stiffness. There are some patients who need to wear a brace after surgery. This will be told to you the day after surgery if there was a problem. Exercising every day is the best way to make progress with the knee replacement. And remember that the medications do need to be taken, including narcotics in many cases, around the case of knee replacement. Icing is also important in my mind to help with swelling. Speaking of icing, you'll be given an ice machine at the hospital that you can fill with ice that hooks to a bladder that goes around your knee. Around the hip, you can place ice bags on the outside of your thigh. The importance with getting range of motion cannot be understated. Average range of motion after knee replacement is approximately 120 degrees, but if you get to 110 or 115, you should be able to do 95% of activities that people require from their knee. Doesn't mean you should stop at that, but that is a goal that's quite important. Let's move on to occupational therapy. Occupational therapists help you with things that you take for granted. This includes activities of daily living, bathing, putting on socks and shoes, transferring from a bed to a chair, and they also teach you how to use some handy things that you might see in a hip or knee kit, such as this. This hip kit includes a number of accoutrements that can help you put on socks and shoes, grab things at a distance, and put on clothes, and also help with bathing. They can show you how to use these things that can be quite helpful. This can be purchased on Amazon or other online vendors for $40 or less usually. The leg lifter is also a nice thing to get, especially for knee replacement. This lifter is something that you can use to help lift your leg with your arms. You might look for one of these as well. They'll show you this in the hospital too. In regards to activity level after hip or knee replacement, remember we first of all want you to be safe. We don't want you to fall. Also, realize this rule of thumb for activity. About the first week after surgery, you should walk about a block per day. The second week after surgery, you should walk about 2 blocks per day, and so on. Don't be discouraged with the ups and downs after surgery because there's always going to be some. Most people head home after surgery. It's about 90% of people. There are still some people that go to a rehab facility, although that has become less common. 90% of people go home after 1 to 3 days, and home physical therapy goes for about 2 weeks. You might look into other shared services, and you can check with our nurse navigator about this. Also, family and friends may understand some options that you have. It's about 1 out of 10 if you don't go to home that will go to a skilled nursing facility, also called a SNF, SNF. Many people ask who goes. There needs to be a medical need for you to go and for insurance to pay, whether Medicare or a PPO or HMO type of insurance. Those people who go are those over the age of 80, those with a medical condition requiring nursing care, and those with poor or unsafe mobility. Just because you live alone does not qualify you for this benefit. Realize that there are some people who have gotten stuck paying for this if they don't qualify with a specific medical reason. If you do go to a skilled nursing facility, you'll be under the care of a geriatrics team, ideally from the clinic. They will manage your medications. If there's an orthopedic issue that arises, they will call us, and 7 to 10 days after, we will see you in the clinic. Please pack your bags because you will be going home soon if you are at a skilled nursing facility. It's very rare for people to stay more than 1 week. Here's the final checklist for home. You need to be cleared by your physical and occupational therapist in the hospital. You need to be cleared by the hospitalist from the clinic. You should be walking and able to take stairs. Your pain needs to be controlled with oral medications. Your vital signs also need to be stable, and you should be eating a regular diet. Medications should be ordered and available for home, and I'll tell you more about this in a moment. Durable medical equipment should also be ordered by the case manager, and home physical therapy should be arranged. If these things have been done, you should be ready to go home. Medications for home include a blood thinner to limit blood clots, a narcotic pain medication, anti-inflammatory, a stool softener and acid blocker, and any other medications unique to your case. Here's the blood thinner that's generally recommended, called Lovenox. This is an injectable heparin that we recommend you take for 10 to 14 days after surgery for most patients. This may be extended up to 30 days, and for those of you on another blood thinner or with a special circumstance, you may have a custom plan. This is injected with a small needle into the belly, and you will need to rotate this through different sites after surgery. The nurses will show you how to do this. There is a rare complication with Lovenox, which is severe bleeding. If you see a large raspberry about your belly, you need to stop taking the medication and call us. This is what we mean by a raspberry. Not a small bruise, but an actual large purple blotch around your belly where the injection is. So if you see this, you do want to stop taking the medication. In this case, and after you finish the 10 to 14 days, you will be counseled about taking aspirin. Aspirin can be used as a mild blood thinner to help prevent blood clots. After Lovenox is completed, I recommend transitioning to taking baby aspirin once a day for 4 weeks. This is the 81 milligram aspirin that's available over the counter. Narcotic pain medications are prescribed for up to 6 weeks after surgery. This is especially relevant for knee replacement patients to help you get your range of motion. You want to take the lowest amount of narcotic available or needed to achieve pain relief, and you want to be conscious to decrease the dose over time to get off of those narcotics. Our nurse navigator has a nice diagram to help you manage the medications and decrease the dose. Please ask for that. Anti-inflammatory is important in both hip and knee surgery, but for different reasons. Around hip replacements, we want to prevent the formation of new bone, which we call heterotopic bone, during the first days after surgery. But we also don't want to prevent your bone incorporating around the prosthesis. For that reason, we'll ask that you take Celebrex or ibuprofen for 10 days after hip surgery. After knee surgery, however, you'll want to take this for 30 to 60 days to help with pain relief and to help with getting your range of motion back. You will be given this prescription when you're at the hospital. There are other agents, including Tylenol, as well as nerve modulating agents. You want to take the Tylenol in addition to narcotics and anti-inflammatories. Realize there is a maximum dose of 4 grams per day, but you can take this in 500 or 1,000 milligram doses several times per day. Depending on your age and amount of pain you're having, you may also be prescribed Neurontin or Lyrica. These are nerve modulating agents that can help with pain control. These can be taken with other agents, but they also can be sedating, so they may not always be used. We recommend, as of spring 2019, that you consider signing up for Now RX, which is a same-day delivery pharmacy. More than 90% of our patients have actually elected to use this, and medications are actually delivered to the hospital. Some patients will continue with the services at home as it is cost neutral. We also have no ownership in this company as a disclosure, but our patients have been very satisfied. You might also invest in a small medication organizer because you will be on these medications at some level for the first month or so after surgery, and staying organized can be helpful. Here's a picture of me with my new bride. You might ask, why is her picture here? Her picture's here because she is a plastic surgeon and wound care specialist. She makes sure that I give the utmost and the best care for your surgical wound. We want it to look good, but we especially don't want it to get infected. You'll be given most likely a waterproof bandage around your hip or knee. When you leave the hospital, you can shower, let water run over the bandage, but you should notify us if there is a particular problem. If it's starting to peel up at the edge, but otherwise looks okay, you may be given a bandage that you can replace. But if there is redness around the bandage that is spreading, or there's bleeding or spotting more than the size of a $50, or a smell that's coming from the bandage, you should tell us. This is worth a message and or phone call depending on the seriousness. For most people, there's not a problem, and for more than 90% of people, showering works quite well and the bandage stays durably. Here's another picture of a loved one of mine. This is my sister. I have a picture of her because she is a general surgeon. And when I started in practice, I had a patient who'd been dealing with constipation. I called my sister. She's a highly trained general surgeon at Johns Hopkins. And I said, "Sis, I have a patient who's dealing with constipation after surgery." Her answer to me was, "Don't ever call your sister about constipation." But realize there's a lot to do to prevent constipation. I think that's the most important topic here, given that you will be on anesthesia, somewhat dehydrated, and potentially taking narcotics. We want you to have a smooth stool after surgery without diarrhea. Here is a tip. You may take Miralax, Miracle Laxative, a few days before surgery. Take this once or twice a day with a full glass of water. If you do develop a loose stool, please stop taking this. You should also have a bowel regimen to take after surgery, including Colace and or Senecot. There are other medications to take based on your preference. Let's talk about postoperative swelling after surgery. It's very common to have swelling for 6 weeks, sometimes longer, after hip or knee replacement. About 4 times per day, you should keep the leg elevated on multiple pillows to get the swelling from coming down. Ice will also help around the knee replacement, and you might consider using compression hose that are easily available up to the knee. You do need to watch that this is not cut into your skin, but these can be very helpful for up to 6 weeks. They're not mandatory, but they can be helpful to limit swelling. There are many different shapes, sizes, compression types, and colors available. You can get a moderate compression grade in this case. Again, you will have the ice machine to help with this, but elevation and use of compression hose can be helpful. Here's the follow-up plan in the clinic, both short and long term. So, you've had your surgery, you stayed in the hospital for 1 to 3 days. Most people will be going home, and whether you've gone home or to a skilled nursing facility, you will want to check in at the clinic 10 to 14 days after surgery. At this time, you will see a physician's assistant who is supervised by a surgeon. At 6 weeks, you will see the surgeon. You will have x-rays evaluated, range of motion checked about the knee, and a hip with relaxed precautions at that time. At 3 months, you should also see the surgeon. Also at 6 months, at 1 and 2 years, and then if all is going well, every 3 to 5 years after that. Please do not wait to make your appointments. In fact, Jennifer or one of the nursing staff should help make the 2 and 6 weeks appointments when you're scheduling the initial surgery. As a refresher in regards to physical therapy about the knees, realize that getting range of motion is important. You'll have home physical therapy for 2 weeks. You need to make then outpatient appointments to continue that physical therapy for up to 3 months. Please make these appointments early, in fact, before your surgery. We can give you a list of recommended referral locations from the clinic. A goal is to get 90 degrees of flexion by 4 weeks after surgery, ideally more. Several percent of patients will struggle with stiffness, and some may require manipulation under anesthesia. This means you need to stay motivated, engaged with physical therapy, and working proactively on your pain control. Hip physical therapy, again, hip precautions are maintained for 6 weeks. This helps prevent the risk of long-term instability. The risk is low, about 0.5%, but it still can happen. So remember, don't pick things off the ground, don't cross your legs, and don't hyperextend your hip for 6 weeks. You also don't want to exceed any strengthening limits that have been taught to you. Not everybody needs outpatient physical therapy, but at week 5 or 6, we may have you begin this. At the end of the day, walking tends to be the best exercise after hip replacement surgery. Who to call and when to call. Please call 911 during your recovery if you have significant shortness of breath, chest pain, loss of consciousness, or an issue with dislocation or fracture around the joint. You will know if one of those things has been happening. Please call the clinic if you're having fevers over 101.5, significant bleeding from your wound, or concerning drainage or smell or concern of infection around your surgical site. Give adequate time for medication refills, specifically for narcotic medications. Remember, we need to use a special computer and server code to authenticate these controlled substances. They are high risk for abuse and as such are getting a lot of attention from local and federal authorities. Hip replacement patients often need very little in terms of narcotics, sometimes just up to 2 weeks and often less. Knee replacement average duration is about 4 weeks. You need to decrease the dose of these and contact us during working hours to get you these medications. After hours and evenings, it can be very difficult, if not impossible, to get them. Next, I will cover a potpourri of issues as we finish this talk in regards to things that come up around joint replacements. We also, again, encourage you to come to the in-person seminar so that you can learn more from us and from others as they ask questions. But here are some frequently asked questions that come up. First of all, why does my knee replacement make noise? Well, with a knee replacement, you cannot be a cat burglar Your days are limited. Because the metal and plastic parts will tap and click, this tends to be permanent. We don't see this in hip replacements, however. Knee replacements feel warm for months after surgery, sometimes beyond 6 months. This does not mean an infection. This is part of the normal healing process. Even some redness and warmth, but realize this is common. If you're having fevers or chills or significant swelling or stiffness, please don't hesitate to contact us. Sometimes testing needs to be done to make sure that you don't have an infection, but warmth is very, very common. Hip replacements will feel long for 3 months after surgery. We do a lot to make sure that your leg lengths are symmetric, but because the muscles have not tightened up, that leg will feel long for several months after surgery. We'll show you how we measure the leg lengths at the time of surgery, and we'll show you on your x-ray what the true discrepancy might be. It's less than several percent of people that will need to make any correction for leg length issues. In fact, we use an intraoperative digital health technology called JointPoint to help with this, where we can do intraoperative templating and analysis using x-ray and special software to ensure leg length position for hip replacement. Why does my hip or knee have numbness or burning on the outside of the incision? Here's the reason why. There's a specific nerve that runs over the brim of the pelvis on the outside called the lateral cutaneous nerve of the thigh. This is irritated and damaged at the time of the surgery. This is unavoidable. 5% of people will actually have numbness in this area. A similar concept serves the front of the knee, where most generally on the outside of the knee incision there may be a similar feeling. What about travel after joint replacement? 2 issues. First of all, we highly recommend you stay from long cross-country and international flights for 6 weeks after surgery. This is to help prevent the chance of a blood clot. Flying in elevation does increase your risk. If this is unavoidable, please talk with us so we can limit your risk in terms of changing medications for you to be on. Also, there is no special card or carrying identification card if you have a hip or knee replacement when traveling. Please inform TSA agents that you have a hip or knee replacement, and if you're going through an x-ray machine, about 50% of the time this will be set off. Quality control is important for us after surgery, so please make your follow-up visits. Please get your follow-up x-rays at the cadence that we discussed at 3, 6, 12 months after surgery, also at 2 years, and then alternating 3 years after that. Also, we thank you in advance for filling out surveys that you may get so we can keep your care and care of others as good as it can be. Please fill out the patient-reported outcome surveys. In the case of the hip, this is called the HOOS, the Hip Osteoarthritis Outcome Score. In the case of the knee, it's called the KOOS, or the Knee Osteoarthritis Outcome Score. And also, if you've had a good experience, please tell us, and you can review us on Yelp or Health Grades, where many patients will go to leave their impressions of our care. Let's talk about long-term precautions after hip replacement. How do I keep my joint replacement lasting long and functioning well? First of all, we recommend against any jumping, running, and heavy lifting after surgery. You want to limit high impact loading across the joint replacement so the parts do not get damaged or get loose. Lower impact activity, whether it's cycling, golfing, or skiing, are all fair game. Of course, tennis, skiing, and some other moderate impact activities, there is a spectrum. So you want to stay within yourself and not adopt any higher impact activities than you need to do. But we have many happy skiers, golfers, and tennis players who have joint replacements. It's important to prevent your joint replacement from getting infected. The dentition, the teeth, tend to be the major area of concern because there are bacteria in the mouth that can go into the bloodstream and get to your joint replacement. This happens sometimes around the time of a dental cleaning. Please ask for an antibiotic prescription to take 1 hour before getting a dental cleaning. If you have an infection that develops, also be proactive about getting this treated. Amoxicillin, however, 1 hour before dental cleaning is recommended for life to prevent dental infection. If you cannot tolerate antibiotics, please talk with us about the risks and benefits of this. Also, please care for the skin, especially around the leg where you've had hip or knee replacement. Dry, cracked skin can get infected and can ascend the leg and go to the hip or knee replacement. Using Eucerin or a similar cream can be helpful to keeping the health of that leg. There are many learning resources, including this seminar that you just watched. Please give this to family and friends. We also have other joint replacement videos available on our website. We have a printed workbook available as a PDF, and we also have a link to AAHKS, AAHKS, that we would recommend you look at for other advanced topics. These are videos through our major hip and knee society. These are important phone numbers that you may already have, including a long-time phone number from the clinic, the Center for Total Joint Replacement, the Sequoia Hospital Nurse Navigator, and the Now RX Pharmacy Delivery. Also, please sign up for My Health Online if you are not already a member. Finally, I have a picture of me and my father. You ask why I have this here. This was just about a year ago. This was a place in the Rocky Mountains where he took me skiing when I was quite young. An absolutely great place to ski, wonderful snow. And unfortunately, there became a time about 10 years ago when not only was he unable to ski, but he was unable to walk without a limp, go bike riding, or travel. And despite him being a physician, he had no idea that he had hip osteoarthritis. He also had knee osteoarthritis, and over a period of a few years, he had both his hip and knee replaced. He has been a model patient and has gotten back to skiing and many other activities. It's been fantastic to watch him go through this. And now at the age of 78 or 79, he's still staying quite active. I'm proud of him. I certainly was not his surgeon, but did help give him some guidance. And by following some of the principles I taught you today, I, too, think that you can get through this safely, comfortably, and with a great long-term outcome. So thank you very much for listening if you've made it this far, and I look forward to seeing you in the clinic, and look forward to seeing you get better after hip or knee replacement. Thank you very much.